Usually, when we talk about a medical diagnosis, there's this expectation of, precision.
Oh, definite.
Right. Like you break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is, broken.
Yeah, a simple fix.
Exactly. We like things to be visible, uh, easily categorized, quickly fixed. But then you step into the world of cancer survivorship and, well, the long-term impacts on the human body.
Suddenly that X-ray machine is essentially useless.
Right. It's broken. We're looking at a diagnostic and treatment landscape that is just incredibly murky.
It is the absolute definition of diagnostic muddy waters. I mean, we are looking at the really complicated intersection of life-saving cancer treatments and the brutal realities of the quality of life that comes after the cancer is technically gone.
Yeah, and that is exactly why we're here. Welcome to the Deep Dive. Our mission today is to cut right through that muckiness for you.
We really want to get into the details on this one.
We do. We are exploring a highly specific, but just critical intersection in women's health, specifically the aftermath of pelvic radiation.
Which is a massive topic.
Huge. And we have a really dense stack of sources on the table today. We're talking medical guidelines, FDA warnings, oncology reviews, clinical trials.
Lots of data.
Yeah, we're pulling from the American Urogynecologic Society, or AUDS, the UK's NICE guidelines, the International Society for the Study of Vulvovaginal Disease, and a few specific phase 1 and phase 2 clinical trials.
And we are using all of those sources to answer one central, really high-stakes question. Can pelvic radiation actually increase the risk of chronic pain and severe complications if a patient later undergoes energy-based vaginal treatments?
Okay, so let's unpack this. Because pelvic radiation saves lives.
Oh, absolutely. No question.
There's zero doubt about that. But it leaves lasting, sometimes just devastating damage on vaginal tissues.
It really does.
And right now, we are seeing this massive surge in energy-based devices. Think lasers and radiofrequency treatments. And they're being marketed as this sort of, I don't know, cure-all for vaginal atrophy and pain.
Right, like a magic wand.
Exactly. So to understand if these two things actually mix, we first have to understand what pelvic radiation actually does to the cellular environment. So let's start with the fallout.
Yeah, so radiation therapy is commonly used for, well, cervical, endometrial, anal, and rectal cancers. And the objective is obvious, right? Eradicate the cancer cells by damaging their DNA.
Which is great, except
the problem is that radiation beams, they don't really differentiate between a rapidly dividing cancer cell and, a perfectly healthy cell right next to it.
wait, it's not a sniper rifle.
Exactly. It's collateral damage.
Right.
They cause profound, acute, and late-stage damage to the entire pelvic region.
And the sources detail exactly how this plays out over time.
Yeah.
And I think it's important to note this isn't just a temporary burn that fades away.
No, not at all.
When radiation hits the vaginal epithelium, that's the lining of the vagina, and the small blood vessels around it, it causes decreased blood flow, tissue hypoxia, and this rapid loss of elastin.
And that hypoxia is really the main driver of the long-term damage here. I mean, the tissue is literally starving for oxygen.
Because the blood vessels are wrecked.
Right. And because the fast cell turnover of the normal lining is interrupted by the radiation, the tissue just stops regenerating properly.
Wow.
Yeah, and that leads to something called hyalinization and fibrosis. The body essentially replaces healthy, elastic tissue with this stiff, rigid collagen.
Which just sounds incredibly uncomfortable.
It is. Plus, you get accelerated atherogenesis, so those tiny blood vessels that feed the pelvic floor, they become hardened, narrowed, and in many cases, completely obliterated.
So it's kind of like taking a brand new stretchy rubber band and just leaving it out on the dashboard of your car in the baking summer sun for like weeks.
That is a highly accurate, if terrifying way to picture it.
Right. Because when you finally go to pull it, it doesn't stretch anymore. It's lost all its elasticity, it's brittle, and if you pull too hard, it just snaps.
Yeah, and the medical term for that loss of stretch and narrowing is vaginal stenosis. The canal actually narrows, it shortens, and it can even obliterate entirely if scar tissue forms adhesions that literally fuse the vaginal walls together.
And the numbers we found on this for you are just staggering.
They really are.
According to the reviews, within the first 3 years after pelvic radiation, vaginal stenosis affects up to 50% of endometrial cancer survivors.
Which is huge.
And it's 60% of cervical cancer survivors, and an astonishing 80% of anorectal cancer survivors.
And the daily reality of those statistics is severe dyspareunia, which is just intensely painful intercourse.
Right.
It causes a complete lack of natural lubrication. The mucosa becomes so thin and dry and fragile that it can tear and bleed with like even minimal friction.
Which means even basic medical care is impacted.
Right. Oh, massively. In many cases, routine necessary gynecological examinations, to check for cancer recurrence, they become physically impossible to perform without sedation.
That's just, man. If 80% of anorectal cancer patients are experiencing this level of anatomical change, you'd think we'd have I don't know, a highly advanced, elegant medical solution.
You would think so.
But looking at the globally accepted prevention strategy, the main treatment is vaginal dilator therapy.
Right. Patients are given a kit of smooth, cone-shaped, graduated plastic or silicone cylinders.
Just plastic cylinders.
Yeah, and they are instructed to insert them into the vagina regularly, often multiple times a week, to physically break down those adhesions.
To basically mechanically stretch the canal so the scar tissue doesn't permanently fuse closed.
Exactly.
We read through the patient experience guidelines on this, and honestly, it sounds grueling. The sources mention that the act of dilation can be just excruciatingly painful.
It is a constant physical reminder of their cancer trauma.
Yeah, and as a result, the compliance rates are incredibly low. Like one study noted that over time, compliance with dilator therapy can drop to between 5 and 14%.
It makes complete sense why.
I mean, you are asking someone who has just survived cancer, who is dealing with incredibly fragile, painful, irradiated tissue, to routinely perform a painful mechanical stretching exercise in their own home.
Right, along with applying copious amounts of localized moisturizers just to tolerate the plastic cylinder. It's a massive physical and psychological burden.
So if a plastic dilator is the best analog solution we have, it's really no wonder patients are turning to high-tech, laser-based alternatives.
They're desperate for a better option.
Exactly. And the market is suddenly flooded with energy-based devices, or EBDs. We're talking about fractional CO2 lasers, erbium YAG lasers, diode lasers, and radio frequency devices.
Right, the flashy new tech.
But looking at the specs for these machines, they all seem to rely on this really counterintuitive premise, which is controlled injury. Like they are purposely causing microburns to force the body into a wound healing response.
That is the exact mechanism. They deliver thermal energy heat, or they create microablative injuries in the submucosal layers of the tissue.
Okay.
So when the tissue gets heated to a specific temperature, usually around 42 degrees Celsius for radio frequency, or when a laser vaporizes the water in the tissue, it activates heat shock proteins.
Like an alarm system.
Exactly. It's an alarm system that stimulates cells called fibroblasts.
And the fibroblasts then rush into the area to repair the microscopic damage, right?
Yeah.
By producing brand new, healthy collagen and elastin.
That's the theory, yes.
But wait, here's where it gets really interesting. And we're looking at the biology raises a massive red flag for me.
Okay, let's hear it.
If pelvic radiation has already caused massive thermal-like damage to this area, if the radiation has already destroyed the blood vessels, severely reduced blood flow, caused hypoxia, and created rigid scar tissue, how does causing more thermal injury with the laser actually heal the tissue?
It's a great question.
I mean, aren't we literally just adding fire to a burn?
What's fascinating here is that your intuition hits on the exact physiological paradox at the center of this whole medical debate.
Really?
Yes, we have to clearly separate a patient going through natural menopause from a patient who is a radiation survivor, because they represent two entirely different biological environments.
Okay, so in genitourinary syndrome of menopause, just regular natural menopause, the vaginal tissue becomes thin and dry because the ovaries stop producing estrogen.
Right.
But the crucial difference is that the underlying vascular structure, like the actual plumbing, is still intact.
Exactly. If you use a laser to create a microinjury in a menopausal patient, the body still has the blood supply and the cellular machinery to mount a robust, healthy healing response.
The fibroblasts have the oxygen and nutrients they need.
Yes, to build that new, supple collagen.
Right.
But irradiated tissue suffers from what is formally called radiation fibrosis syndrome.
The infrastructure itself is broken.
The small blood vessels are permanently gone. So inducing a wound healing response in tissue that no longer has the blood supply or the oxygen to heal properly, that's taking a massive biological gamble.
Because you are demanding a regenerative response from a tissue bed that is fundamentally crippled.
Precisely.
It's like trying to soften a piece of tough, overcooked meat by throwing it back onto a blazing hot grill.
Oh, that's a visceral image.
But it's true, right? You aren't regenerating it. You don't have the biological moisture or cellular life left to quote-unquote heal. You're just searing it into something even tougher and more damaged.
That analogy perfectly captures the danger. And this is where the biological theory transitions to real, documented medical warnings from major institutions.
Yeah, let's get into those red flags for everyone listening.
Yeah.
Because in 2018, the FDA issued a safety communication explicitly warning against the use of energy-based devices for vaginal rejuvenation.
Which was a big deal.
Yeah, they noted a lack of robust scientific evidence and cited serious adverse events. And following that, the International Society for the Study of Vulvovaginal Disease issued a statement.
The ISSVD.
Right. They basically said, the claim that these energies can be safely used in patients with a history of pelvic radiation is simply not sustained by evidence and is highly misleading.
And then the UK's National Institute for Health and Care Excellence, NICE, they published an overview that documented specific case reports. And I want to stress, these aren't just abstract statistics.
No, these are harrowing timelines of real patients.
Real patients who sought relief through this tech and ended up in a much worse position.
Yeah, one case in the NICE report really stands out to illustrate the timeline of this damage.
Sure.
So this patient had mild dyspareunia, some mild pain with intercourse, before starting laser treatment.
Right. She was just looking for an improvement in her quality of life.
And she went through 3 courses of laser therapy. But instead of her symptoms improving, the pain became progressively and severely worse over the next few months.
And the examination findings 10 months after her treatment were alarming. She developed moderate vaginal dryness, vestibular inflammation, and most troublingly, pelvic floor hypertonus.
Meaning the muscles of the pelvic floor were locked in a constant, agonizing state of tension.
Exactly. She had active spasms of both the levator ani muscles and the vaginal muscles.
God.
And the biological reason behind this is basically a defensive reflex. When you apply thermal trauma to already heavily scarred, irradiated tissue, you can damage the already fragile nerve ending.
So the body perceives this laser heat as a severe attack.
Yes, an attack on a vulnerable area. In response, the pelvic floor muscles just lock down to protect the pelvis, resulting in chronic hypertonus and spasms.
And there was another patient in that same NICE report who had a very similar outcome. Severe pain upon penetration that only started after 3 laser treatments.
Accompanied by dense scarring.
Right, on the anterior and lateral walls of the vagina. They actually ended up needing intravaginal Valium, topical hormones, and intensive physical therapy just to manage the new, much worse symptoms that were directly caused by the laser intervention.
The device that was marketed to fix their pain actually amplified it. It added nerve damage and muscle spasms to an already difficult survivorship experience.
Which is just heartbreaking.
It really is. And this is why the American Urogynecologic Society, AGS, was so definitive in their clinical consensus statement.
Yeah, reading through the AUGS report, they clearly state there is virtually no robust literature supporting the use of energy-based devices for radiation-induced vaginitis.
The data just isn't there.
The data isn't there to support the safety claims, but what really blew my mind in that report was the revelation about the manufacturers themselves.
Oh, this part is wild.
Right. Despite how aggressively these devices might be marketed by individual wellness clinics or, med spas, the engineers and manufacturers who actually build these laser and radio frequency devices often explicitly list a history of pelvic irradiation as a relative or even absolute contraindication for their treatments.
The people who design the machines are putting it right in the manual. Do not use this on a cancer survivor who has had pelvic radiation.
Because they know.
Exactly. They understand the mechanics of radiation fibrosis syndrome and the absolute inability of that specific tissue to recover from thermal injury.
It highlights a deeply concerning commodification of vulnerability in the medical market.
That's a good way to put it.
Women dealing with radiation stenosis are desperate to reclaim their bodies, to alleviate their pain, to restore intimacy. And these devices are presented in these glossy brochures as a quick, modern, painless fix.
And the marketing frequently takes the success rates seen in healthy menopausal patients and deceptively projects them onto cancer survivors.
Blurring the line between a routine cosmetic procedure and a highly dangerous intervention on an irradiated pelvis.
It's a huge problem.
Now, we always want to look at the full stack of sources, and we promised you, the listener, multiple perspectives on this. Is it universally terrible in every single clinical trial?
It's a fair question.
Because I found a study in our research that introduces a fascinating twist to this narrative. It's the Perona All study from 2020.
Ah, yes. The Perron study is a crucial piece of the puzzle. It was a phase IN2 study involving 43 women who were suffering from severe vaginal shortening, atrophy, and stenosis, specifically resulting from pelvic radiotherapy.
Right. And they treated these women with a CO2 laser, doing 3 sessions a month apart. And the results were surprisingly positive.
They're positive.
They documented a 28% increase in vaginal length and a 57% improvement in the vaginal health index, which measures things like elasticity, moisture, and pH.
And the most surprising part,
0 adverse events and 100% patient compliance. The patients actually stated they wanted to repeat the therapy if it became necessary again.
it's quite the contrast.
It is. So how do we reconcile this data? Why did these 43 irradiated women see massive improvements, while the women in the 9C report ended up with agonizing muscle spasms and new scarring?
Well, if you connect this to the bigger picture of laser technology, the answer lies in the highly specific type of energy used, the depth of penetration, and the meticulous clinical setting.
Okay, break that down for us.
The Perron study specifically utilized a non-ablative CO2 laser.
Okay, so ablative lasers purposefully vaporize the surface layer to create those microwounds we talked about earlier.
Right.
But non-ablative lasers bypass the surface layer entirely and just deliver gentle heat to the underlying tissue.
Exactly. In a severely compromised, irradiated vagina, the surface lining is incredibly thin and fragile, so protecting that surface layer is paramount.
Makes sense.
By using a non-ablative setting, the researchers in the Perron study might have found the exact temperature threshold to stimulate a mild, positive fibrotic remodeling without crossing the line into causing a catastrophic burn that triggers nerve damage and muscle spasms.
So it is a microscopic knife-edge balance between stimulating the tissue and destroying it.
A very narrow window, yes.
But we have to temper the optimism of that one Perron study with other highly controlled data. For example, the Revitalize trial.
Right, that one is really illuminating.
This trial looked at breast cancer survivors. Now, it's a different kind of cancer, meaning no direct pelvic radiation, but it's a population dealing with severe medical menopause and extreme tissue atrophy from systemic cancer drugs.
And they conducted a randomized sham-controlled trial, so some women received the real laser treatment, and a control group received a fake sham treatment.
Or to placebo.
Yeah. The machine sounded like it was working, the whole clinical ritual was performed, but the device delivered 0 thermal energy to the tissue.
And the findings are just a massive aha moment. The laser treatment was found to be no more effective than the sham treatment.
And not only that.
Right. Furthermore, the women actually tolerated the sham treatment better than the real laser. But looking at the mechanisms we've discussed today, the sham treatment wasn't just a psychological placebo, it was actually providing a physical benefit.
The sham treatment worked remarkably well because the process of inserting the smooth, lubricated wand of the inactive laser into the vagina effectively acts as a mechanical dilator.
Wow.
The clinician is moving the wand around, massaging the pelvic floor muscles, and physically stretching the tissue.
So the women in the placebo group were accidentally receiving the gold standard of care mechanical dilation and pelvic floor massage without adding the destructive thermal trauma of an active laser.
Exactly. The laser wasn't doing the healing.
The physical stretching of the wand was doing the healing.
Right. The researchers concluded that the laser itself was not effective for that specific survivor population. Any overall improvements noted were likely due to the mechanical dilation of the wand and the placebo effect of receiving attentive clinical care.
Okay, so what does this all mean for you, the listener? We've gone from the devastating cellular biology of radiation to the false promise of high-tech lasers through the horror stories of worsening pain and spasms in the NICE guidelines.
To a glimmer of highly controlled hope with non-ablative tech.
And finally back to a study proving a smooth plastic wand works just as well without the burn risk. Where does that leave a patient today?
Honestly, it leaves patients and their advocates in a position where extreme caution is the only logical path forward.
Yeah.
While energy-based devices hold tantalizing proven promise for general natural menopausal symptoms, using them on a pelvis that has been permanently altered by radiation is a high-stakes gamble. The tissue's vascular infrastructure is simply gone.
You are risking severe, life-altering complications. Chronic burning, new layers of rigid scarring, levator antispasms, and progressively worsening pain.
This is exactly why the FDA, AUGS, and the ISSVD all urge extreme caution, and why the device manufacturers themselves list radiation history as a contraindication.
They know the risks.
Yeah, and while the Perron study shows there might be a very narrow, highly controlled clinical pathway forward using specific non-ablative settings, it is absolutely not ready to be a walk-in procedure at a local med spa.
Right. It requires an expert urogynecologist who deeply understands the cellular reality of radiation fibrosis syndrome.
Absolutely.
This raises a really powerful question to ponder as we wrap up this deep dive. As oncology gets better and better at saving lives, which is an incredible triumph of modern medicine, the population of long-term cancer survivors is booming. People are living decades past their initial diagnosis.
But are our rehabilitation technologies actually keeping pace with the complex, permanently altered biology of survivorship? Or are we, as a medical industry, just throwing generic, off-the-shelf cosmetic fixes at uniquely traumatized bodies and hoping for the best?
We have to demand solutions built specifically for the biology of survivorship, not just hastily repurposed tools built for someone else.
Well said.
Because the X-ray might show the cancer is gone, so we consider it a clean fix. But the reality is that the diagnostic machine is broken when it comes to the aftermath. We can't treat a radiation survivor like a standard patient. We have to respect the trauma the tissue has endured.
So true.
Thank you so much for joining us on this deep dive. Keep looking past the glossy marketing, keep reading the fine print, and always keep asking the hard questions about the medical tech you encounter. Until next time.